Hey guys, welcome back to another episode of the Physiology Secrets podcast. Got a special guest in today. I got Aidan here. Not only is my physio, but he's a physio to a number of athletes that do come in and see us at Mets. Pretty of a gun triathlete, going through a bit of a slump in training with a bit of overtraining at the moment. But great to have you on. Wanted to get you on particularly to talk about a few topics that we do get questions on, that having a physio sort of go through them with us is going to be really useful. So the first one that I want to tick off is we get a lot of questions about foam rolling, trigger points, using massage balls, etc. Do you want to just take us through your thoughts on benefits? Is it worth it? What is going on with things like trigger points? Are they a thing, or is it kind of a bit still up in the air? And just briefly touch on the key aspects that athletes and coaches need to know about.
Sure. Thanks for having me on the podcast today. So I guess with foam roller and self-massage and those kind of techniques, the most important thing with these is that they're really harmful. They're a safe technique to do, and the risk of injury, the risk of causing further problems is very, very low. So if athletes or people who are non-athletes do that, there's nothing particularly wrong with it. But maybe I'll talk a bit more about where the evidence shows the best results are with foam roller. So with foam rolling, often they're prescribed to increase flexibility, whether it's a hip joint or a knee joint, or whether it's muscle flexibility or length. Some of the evidence does show that muscle length can be improved or joint flexibility can be improved, but it's normally pretty temporary or pretty transient. Maybe it lasts for a couple of hours, maybe a bit less. So if you're looking to increase flexibility for that time period, foam rolling is a good thing to do in that situation. So maybe if you're doing, maybe to use the triathlete example, if you're doing a swimming session, particularly with some hard swimming where you need a lot of shoulder flexibility, that might be a good use of your time to do some foam rolling prior to the swimming session. Maybe on the other hand, if you're doing an easy run, you don't need a lot of flexibility to do an easy run at a moderate pace, it's probably less important to do foam rolling or trigger point work before that session. From a long-term flexibility point of view, it probably doesn't make too much difference, but again, if you find benefit from foam rolling or self-massage, it's a good technique to do. The other area where foam rolling or self-massage can be helpful is with muscular soreness, and it tends to be that the muscular soreness is reduced with foam rolling, particularly after strength training. So often after strength training you'll get the next day and even the following day DOMS, delayed onset muscular soreness, that pain you get after unaccustomed activity or eccentric training in particular, and it looks like foam rolling or massage can reduce the effects of that DOMS slightly. So that's the area where I'd usually encourage people to use foam rollers a bit more.
Yeah, so definitely sort of post session where legs are feeling a little bit sore is a good opportunity, but then pre-session as well, if you're just sort of needing a bit of extra range of motion, if you're hitting a bit of a harder session. Like you said, swimming is obviously the good one, with a lot of guys complain about sort of tight shoulders and that in the pool. Just loosening them up before we get in is obviously going to be a good option.
And of the three disciplines with triathlon, swimming is the one that has the most significant flexibility demands, and often flexibility can be a limiter for swimming, particularly in age group triathletes where they haven't grown up as swimmers and they've got shoulders with average mobility and thoracic spines with average mobility rather than exceptional mobility. You see that in elite swimmers, they've got truly exceptional flexibility through shoulders and mid-back, which is what makes them elite swimmers, but a bit harder in triathletes when they spend a lot of time on the bike or running.
Yeah, absolutely. Do you want to just touch on the trigger point aspect? We also hear a lot of athletes hear about trigger points, and they might say they've got a particular spot that when they get a massage ball into it, they get a thumb into it, someone giving them a massage gets their elbow or whatever into it, it's tight, but then they can release it. Do you just give a bit of background on what kind of is a trigger point, if that's the best way of putting it, and then what do we do about these particularly tight areas or these so-called trigger aspects? What are we doing to fix those or release them?
Sure. So trigger points are a bit of a controversial issue, as you've touched on, and there's been lots of textbooks and lots of publications about what are trigger points and where are they, and are they the same on different people. So they've been described as a taut band or a muscle knot or a hyper-irritable piece of tissue. We don't really know why they occur. We don't really know if they're the same between athlete A and athlete B, and the researchers suggested that the ability to find a trigger point between one therapist and another therapist isn't actually that accurate. So what one therapist says is a trigger point in your upper trapezius, another therapist might find a different area. All we know is that they're tender areas to push on, and that may be because there's some cutaneous nerves or small nerves under the skin It may be because you're pushing on a tender, or there's something in that area that's tenderable. We don't know exactly what the cause of these trigger points is, and despite all the advances with the scientific research, we haven't been able to identify, what a trigger point is, either on imaging or on EMG, where they measure the muscle activity or anything like that. So there's been a variety of treatments proposed to treat these trigger points, but I guess it's a little bit hard to do the treatments when it's hard to determine or define what a trigger point is. Yep. So we've got dry needling, which is used commonly. We've got firm sustained pressure, which you can either have with a therapist or with a spiky ball or a foam roller, I guess, or some kind of other massage device. So they're the things that are commonly used. Again, it's generally very, very safe. The risk of side effects, particularly with the spiky ball or other trigger point devices, is very, very low. I have seen a couple of side effects where someone's had a therapist put their elbow on someone's backside for a long time, and they've actually compressed the sciatic nerve enough to give them some tingling into their leg for the next couple of days. So that's an unusual side effect. Other than that, it's normally very, very safe. So if you find significant benefit from it, go for it. Dry needling is a slightly riskier activity. There's a few cases of pneumothorax or lung punctures occurring when the needle pierces the lung. Again, it's very, very uncommon, and if you've got a therapist who's good with their anatomy, it shouldn't be an issue. So those techniques are used. If you find it helpful for you, that's great, and I would very rarely discourage it, but just be aware that the science around trigger points is a bit
sort of
up in the air still.
Yeah, cool. So based on that, the safest way to go about, particularly if you're on your own, is if you've got like a lacrosse ball or a spiky ball, holding on the one spot and then a little bit of movement. Would you go down that path, sort of sitting in the same spot and then try and wiggle around it a bit, or what is it almost a case of, like you were saying before, is it a case of you can either pin the spot and just hold it for a bit and do a bit of movement, whatever basically makes you feel a little bit better is going to be the best outcome? Yeah,
so you can do either. So a lot of the trigger point advice and textbooks looked at doing a sustained pressure. So if you find a sore area, hold the pressure on that area for 45 to 90 seconds, see how it feels afterwards. Yep. And then you can add movement, if you describe, which becomes more of this myofascial release term, which again is a bit of a controversial term, but you're moving over a variety of tissue rather than fixing in the one spot. And then foam roll is a bit more, or massage is a bit more movement again, where you're moving over a lot more tissue, but with a more sustained pressure, I guess. So any of those are good options, whether you want to hold an area for a prolonged period of time, or you want to move the lacrosse ball or the spiky ball over a larger, over the length of a muscle.
Yeah, either sort of work. Yeah, good one. Just a quick one on sort of moving through. You sort of mentioned there's almost those three phases of massage is quite general, and then you scan a bit more specific as you get to using a lacrosse ball. Would you probably recommend going for, like, if you're going to use some of these, use a foam roller first to generally, I guess, if you like to use the term, warm everything up, then get into the more specific targeted areas? Or is it okay to just jump straight in and hit one of those trigger sort of pressure spots on, say, your glutes, for example? Just hit that first and then go the other way and then start moving into more the general stuff. Which way do you reckon probably...
Sure, I don't have too much of a preference. It probably depends on the individual circumstances. So if someone finds they've got one tight area, they might have found a technique that works for that, and I'd be happy for them to stay with that. If they find they need a bit longer and they need to approach the area gently, because often what these firm pressures do is they increase your ability to tolerate pain. You're kind of replacing one pain with another pain for a while. So having a foam roller for a while might, reduce the threat or reduce the perception of pain when you're pushing on that area. So doing a bit of foam roller might make it feel a bit better, and then you can go a bit more aggressive with a lacrosse ball or a spiky ball. So you may find that you get a better result with gradually increasing the pressure through that area, going from a more general foam roll massage into a bit more specific and a bit more of a firm use of a trigger point ball or a lacrosse ball. Yeah,
rather than going sort of 0 to 100 and just bang straight into the area. But I guess if you can tolerate it, maybe.
Again, the downside's pretty good, but if you get some significant symptom relief from having a sustained pressure straight out of the gate, that would be fine. You could do that as well.
Yeah, cool. Second thing I did want to have a chat about today, because again, another sort of common theme that comes up with athletes either coming in or not coming in, if you like, for testing is often around the side of injury, and particularly to do with tendon-based injury. See a lot of runners, a lot of triathletes in particular, having issues with tendinopathies, or particularly Achilles-based based stuff. Do you want to just talk through the common tendon-based injuries that you see and you treat?
Yeah.
What the general, I guess, progression of getting athletes back to fully recovered from those tendon-based injuries, and then maybe using the Achilles as an example of, I guess, that whole process of athlete presents to you with a Achilles-based tendon issue. How do you then take them from when they first come in the door to getting back running, training, almost 100%?
Great. Sure. So as you mentioned, my area of interest with work is sports medicine, but tendon injuries in particular. So I see quite a lot of tendon injuries. We see a variety at the clinic, which is good. We see a lot of Achilles, which is generally in runners, but it can be in non-runners. We see some patella tendon or knee tendon problems, which are generally in people who are doing jumping sports, so basketball or volleyball. Yep. We see hamstring tendon a bit, which is a bit of a mixed demographic. You often see it in people who are relatively sedentary but sit a lot, or you can see it in runners as well. We see a lot of gluteal or outside of hip tendon, which is more in the mid-50s population and older. We see a few shoulder tendon problems, elbow tendon problems like tennis elbow, and also a bit of plantar fascia, which used to be treated a bit differently to a tendon problem, but now is kind of coming under that umbrella of a tendon condition. So with an Achilles injury, it's probably important to talk about the risk factors or things that make you more likely to have a tendon injury. So there's a few that you can't change and a few that you can change. So one of the ones you can't change is that there is a genetic susceptibility to some certain genes that make you more likely to have an Achilles tendon problem. So you can't change that. The other things that make you more likely to have Achilles pain is your blood profile, which is quite interesting. So if you've got poor blood glucose control or you've got insulin resistance, so that's the kind of pre-diabetes, we think you're more prone to getting tendon problems there because the metabolism of the tendons it has a glucose metabolism. So if you've got general health considerations like that, it's worth addressing. The other thing is that elevated cholesterol is a risk factor for developing tendon problems. However, reducing your cholesterol with statin medication or a cholesterol lowering medication further increases the risk. So there's some background considerations. So it's going to be less likely to be an issue in your 20 or 30 or 40-year-old triathlete, but certainly we're seeing someone who's a bit older, who's still very active but has these general health considerations. We need to address those as well, or at least discuss those as well.
So maybe just to cut in, maybe some of those athletes who are coming into things like triathlon in their later 30s, 40s, haven't done much since they were probably early 20s, getting back into sport after 10, 15 years, probably worth checking some of these aspects prior to really fully getting involved again. Yeah,
it's probably worth getting a yearly checkup from your GP if you're above 40, and if you've got some markers of impaired metabolic control. So the blood test I often look for is called a HbA1c, which is a measure of your average blood sugar levels effectively over the last 3 months. Is a good tester for what your metabolic health's like, and that's kind of normally easily available from your doctor if you've got a good reason for it. So you can do that. Then your tendons act like a spring. To use the Achilles in this example, it's good at absorbing energy when you touch the ground and then releasing energy when you push off the ground again. So running is the main sport where you use your Achilles. There's really a trivial amount of load through your Achilles tendon in cycling and in swimming. Where you can see problems with the Achilles is if the total volume of running increases dramatically. So if you get someone who's running 20 kilometres a week and you spend 3 years gradually increasing their load, then 3 years later they're running 80 kilometres a week, often they can handle that load because the tendon's able to adapt, it gets stiffer and more able to work like a spring. You get that same runner and take them from 20 kilometres a week, and over 2 months you go 20 up to 80, so by adding 10 kilometres or so a week, often that runner will break down because their tendon's less able to adapt over that short period of time. So the tendon's really resilient, it's able to adapt to what you're doing to it, but it also means it de-adapts too, so a long period of rest makes it less able to cope with the demands of running. So what we like to see is gradual change in the running volume. It gradually increases over a period of time. And then also with fast running, so sessions, running at half marathon pace or quicker, we like to see that as only a set percentage of your running week, and that's often a higher load through the Achilles as well. So very fast running puts a higher load through the Achilles than moderate paced running. So that's also a consideration in designing a training program and talking about risks for Achilles issues. Footwear is probably a consideration depending on your running mechanics. Often the shoes with a lower drop, so they talk about a shoe drop, so from your heel down to your forefoot. So most shoes will have an 8mm drop, some will have a bit less, so 4mm, particularly racing flats, and then some of the shoes that got quite popular a few years ago, like the the Newtons or some of the, I think it's the Ultra shoes, have a 0mm drop or even a negative drop, so the Newtons actually force you to land on your forefoot because you can't really land on your heel at all. So all those things can put more load through the Achilles, which if you adapt to it over a period of several months, it's actually normally okay. If you try and do it over a week, often it causes problems. So they're the kind of risk factors that we look at for Achilles. In terms of treatment, it's individual, kind of depends on the presentation, and one of the big considerations is which part of the season you're at. So if you get a triathlete and we're in March, so the back half of the Australian season, they might have their A race in April or May, whether it's an Olympic distance race or longer or shorter. In that situation, you're very rarely going to say you should rest completely for 4 weeks and then try and race, because it wouldn't be great advice. They go into their A race of the season unfit. So in that situation, you might be happy to push through a bit more symptoms as long as they're happy to rest at the end of the season or do a bit less at the end of the season. Whereas if you get the same athlete, they had their A race in mid-April and then they've got another couple of months ahead of them when they've got nothing structured, that would be a really good time to really push the rehab a bit harder. So your advice will change depending on what time of the season they're in. So do we pull them back from running? Again, it depends on the time of the season. What we look for is the response to running or response to load. So if you go for a run and there's mild pain, it's okay. The risk of catastrophic things happening to your Achilles during a run is very, very low if you've got some pain. So most people who rupture actually never have pain before. It's this funny paradox. You think people who have pain, they get worse and worse and worse and rupture. The opposite's true actually. Most people who rupture have got nothing and bang. Pop. Your Achilles goes, but it's not the case. So it's safe to push through some pain. We often use a kind of a ceiling of 3 to 4 out of 10 pain during a run, as the cap would tolerate, but it needs to be no worse the next day in an ideal world. So if you do an easy run, a 40-minute run on a Tuesday, and Wednesday it's a lot worse in the morning, or you're a lot sore at a hop, which is a good test for the Achilles, it's a sign you've overloaded the tendon based on what its capacity is on that previous day. Whereas if you do an 8-kilometre run, the next day it's the same or even a bit better, great, green light to do a bit more. And then we'd use that response to kind of dictate how much training we'd do. And we might replace some running with cross training, something like bike or cross trainer or pull, if it's during the season, or even if it's in the off season, and we might prioritise the sessions. We say, right, what's the most important session? That's long run. Let's get long run done, and it's your Thursday track session. Despite track being a bit more low because it's fast, we still need to get some fast work done to be able to prepare for the demands of race season. So, but maybe the 2 easy runs that you do during the week can be replaced by cross trainer, bike, stepper, something else that doesn't put a lot of load through the Achilles. So once we've got a stable base and the symptoms are well managed, then we'd often include a rehabilitation program. It's hard to do this in season when you've already got 3 or 4 or 5 runs or more per week, but often once we can drop the running down a little bit, we'll include a rehabilitation program, which often includes a heavy strength program. We definitely look at gastrocnemius, so your big calf muscle. We definitely look at soleus, which is the deeper calf muscle, which is a bit tricky, and it's often missed, I think, in rehab programs, but soleus needs to be strengthened with your knee in a bent position, so some kind of heavy calf strength, but with your knee bent. And then, particularly if an Achilles injury is long-standing, we'll look at further up the leg, up the kinetic chain. Often people develop some weaknesses in their quadricep muscles or their gluteal muscles if they've been having an Achilles problem for a long time. They get some weakness upstream, so you need to address that as well. And then after that, there's often a few more steps, like including some skipping or hopping drills to get the tendon more able to act like a spring, absorb and release energy. And then a gradual return to running, and it depends on how long they've been off their feet for, about how long we build up to their volume again, and how severe their symptoms have been. But again, we use that next day response, that 24-hour response, as a good benchmark. That's a general outline of how we approach an Achilles problem. The important points to kind of mention are that it's very individual. There's no recipe treatment. There's certainly some recipe treatments out there that we used in the early stages in the late 90s with Achilles problems. And for some people, they'll actually do quite well if it's someone who is generally mid-40s or older, they're a bit weaker than they were 15 years ago, and they're running 2 or 3 times a week. A generic program often actually does pretty well, but if you're not getting a result with that, or if you've got specific requirements about with your sport, you probably should have an individualised program. And we always try and empower people. Know what loads are high for your tendon, know what loads are low for your tendon. As an example, when we get back to running, Very, very slow running actually puts more load through your Achilles. Often will get you doing moderate pace running, not sprinting, but not going deliberately very, very slow. Because when you run very, very slow, you get a big contribution through your Achilles. It can actually be more load than moderate paced running. Yeah, so we make an individualised program, get people to understand what loads are high and low for their Achilles. What are the green light signs to push ahead and do more training? What are the red light signs to hold back and do a bit less training? And most of them can be managed very, very successfully.
Yeah, interesting, and that's an interesting point. I think not just going back in and starting. All right, you're only going to do really slow running because, as you said, if you're running really slow, you're potentially spending more contact time on the ground, probably loading up the Achilles more than what you would be if you're running a bit more moderate pace. So, interesting that probably first thought, and even in my mind before you sort of mentioned it was, all right, yeah, just ease back into running is the first thought that everyone sort of goes through, but actually being able to pick it up a bit, not going flat out straight away, but being able to pick it up a bit so you're getting some load but you're not putting a massive amount, and then you can start getting back into the longer, slower stuff if you need to, or some of the high intensity stuff later.
So to give a kind of example, if someone does their normal long run at 5 minute kilometre pace, I'd strongly discourage them doing 6 minute kilometres when they return from an Achilles injury. And you might get them running at 5 minute pace. Often they might be aerobically not able to handle that for too long, in which case you do a walk run program. You might get them running for 2 or 3 minutes with a 1 minute walk in between. Often though they're quite aerobically fit because they've been able to maintain bike and pull while they've been running a bit less, or even doing more bike and pull while they've been running a bit less.
Yeah, and interesting as well, you've got to consider all the potential other downsides, like you said, maybe quadricep or as a result, or through your glutes as a result of either compensating on one side while you're managing the injury, or if you're not being able to run at all potentially in some of those cases. Just the impact of then running again compared to just being on the bike or in the pool where there's sort of that minimal forceful impact through the knees and that. Do you see any sort of follow-on injuries as a result of coming back too quickly into high running loads?
That's a really good point, and often you see that in elite runners, because often when they've got an injury, whether it's an Achilles or a bone injury like a stress fracture, they'll rest from running because they have to, but they'll do 3 hours of cross training a day. So they're aerobically, their cardiovascular fitness is fantastic. And you see the same thing with triathletes. They might go from 6 or 8 hours a week on the bike to 10 or 12 because they're not running as much. So they come back and they're aerobically bulletproof. But from a musculoskeletal point of view, they're a bit vulnerable. So it's a good point. With the reloading, you're also looking at bony reloading. You don't want them to develop a stress fracture in their shin or in their foot, which is quite common, or even in their thigh, which is a bit less common but still happens, particularly in distance runners. And allow the rest of the joints to reload as well as the tendon that was originally affected, so the Achilles tendon in this example. So it depends on the time off their feet as to how quickly you reload them, but that's an important consideration.
Any sort of last point I want to touch on is almost, if you like, what's better, to just have a bit of Achilles pain and sort of a partial damage to the tendon, or to do the full rupture and have it go, in terms of coming back and then, I guess, susceptibility to re-injury? Which one's better? Because when they talk about, I don't know, like broken bones and that, it's almost better to snap the thing completely than fracture it. Sure. What do you see? Is it sort of similar, you have higher risk of re-injury after having any sort of Achilles injury, or is it a case of the athletes who do completely snap it, once it reforms, rejoins, it's almost good to go again?
I'll talk about rupture a little bit. So most people who rupture, it's probably at least 90%. They have some significant tendinopathy or tendon change in the tendon, despite them normally not having any pain. Again, there's a funny paradox you'd expect if you have an unhealthy looking tendon on imaging that it would be painful, but often it's not the case. They don't look healthy on the scan, but the athlete still functions very, very well. So you're often having a rupture to a tendon that's unhealthy rather than a healthy tendon. With a rupture, there's 2 schools of thought, and neither one has been proven to be better than the other. Often there's been a push for conservative treatment with an Achilles injuries now, so that would put you in a plaster cast for 2 weeks with your Achilles in a short position, and then into a boot after that for 4 to 6 weeks, and then a gradual wean out of the boot, and eventually a return to sport. The other option is a surgical repair. They take you into theatre, general anaesthetic, do an incision on the back of your calf, and they repair the Achilles with sutures. Neither has been proven to be better in the long term. So where by long term I mean 1 or 2 or 3 years after the injury. If you have a surgical repair, the re-tearing rate is very, very low, substantially less than 4%. So once you get through that first couple of months you're out of the boot, normally it's reasonably smooth sailing. It can be hard to get your full strength back, but it's normally a pretty smooth process. With the conservative treatment, again, often it's a smooth process. The chance of re-injury when you went out of the boot is a bit higher. It's not substantial, but it's certainly a bit higher, and that will be very frustrating because you get 3 or 4 months down the track and you can have a re-tear and you can be back at square one, so to speak. And often they progress to a surgical repair at that stage. So that's why you see in most elite athletes they have a surgical repair, not because the long-term results are better, just because they can't afford to have an injury and then 3 months later be back to square one. So on balance, I think it's probably better to have a tendinopathy. Most of them do pretty well. There's very few chronic, grumbly tendinopathies that force you to have dramatic changes to your running program for a long time. Most of them do pretty well. Very few progress to surgery. So most of them, again, I'm probably biased because I might see some of the more bad ones. The ones that get better just get better and they don't go and see a physio. But most of them do pretty well, the normal Achilles tendinopathies. I'd prefer to have that than a rupture. And again, with a rupture, you're kind of off the bike for a while. You're out of the pool for a long time as well. So having a boring old tendinopathy would be better than a rupture, I think.
Just very quickly, for those who are watching and listening who don't fully understand sort of the difference maybe between tendinopathy and a rupture, last little point, and then we'll wrap up. What actually causes a tendinopathy? Or what is it? Is it little sort of partial tears, or is it just a bit of overstress and it's sort of inflamed?
Sure. So the terminology used to be tendinitis. That was the word that was used until the early 2000s. You had Achilles tendinitis or patellar tendinitis. And the itis denotes an inflammatory component, so you've got an inflamed tendon. And some of the research around that time, where they took some samples of the tendon and looked to see if there was inflammatory cells in the tendon, showed that there wasn't, so that they went away from that term of tendinitis and went to tendinosis. So osis means degenerative change, and then they changed it again to opathy. So a tendinopathy is a problem with the tendon, or a kind of partially reversible degenerative change, which sounds a bit like a word salad, but that's sometimes where the academic research takes you. So it's an inability of the tendon to cope with what you're asking it to do, and you can have early stage tendinopathy where the tendon's literally a bit swollen, there's a bit more fluid in it, or you can have a later stage tendinopathy where the normal orientation of the tendon, where you've got fibres of collagen like layers of a rope that are in a line, are disorganised when you have other substance in the tendon. Things like ground substance, new blood vessels like nerves and little veins, undivided cells as well. So you can have this structural change to the tendon. And that may be reversible in the long term, but the important thing to consider, if you've got some of your tendon that's unhealthy, you might have 70% of your tendon that's still pristine, beautiful, healthy, normal tendon tissue, and that can be strengthened and rehabilitated quite easily. And often rehabilitating that healthy tendon is what gets you back to your normal activity levels.
Yeah, cool. Plenty of interesting content to sort of take away, and I mean, we could chat about different things about tendons and re-injury and stuff all day. So I think we'll leave it there. We might have to get you back on with some more episodes in the future, just talking about different types of injuries as well. Great resource we've got in terms of Aidan as well. So if you've got any questions that you want specifically asked in terms of injury and that, like I said, we might have to set up another time to sit down and go through them and sort of help a few guys out with a little bit of advice around what is actually going on with some of these injuries. So hopefully you've enjoyed this episode of the podcast, and we'll see you on the next one.